I'll just welcome everyone to the OTW podcast today. I'm here with Dr. John Peloza and Brad Niemann from 4Web. And so, gentlemen, thanks for joining today. I thought what would be a kind of a fun way to start this out would be just to kind of get to know our guests. And so I'd like to start with you, Dr. Peloza, and just kind of really, we want to know the rest of the story. And I always hearken back to Paul Harvey. You know, a lot of times we have these stories, these narratives that we understand, but we really miss the bigger picture. And so today I was hoping we could kind of widen the aperture and hear from each of you. Just sort of, I mean, here you are 30 plus years into your career, but we want to know the rest of the story. So would you walk us through kind of how you got to where you are and what led you along this probably winding path? Is certainly not a straight line.
Well, that's how far back do you want to go? You know, and I think about growing up and everything. My parents, immigrants, and so the immigrant story and hard work and expected us to do well and try and do the best we could in school and sports and everything. And so that was imbibed. It was imbibed into me that that's what was expected. And always get better and do your best. And so, you know, as a kid, I was always interested in science and technology because I grew up with the space program and astronauts and going to the moon and everything. And so I wanted to be an astronaut, a fighter pilot and all those things. And so I went to the Air Force Academy. And so I majored in engineering. And then I lost my pilot qualification because of my vision. And in the Air Force, if you can't fly, you can't get high command. And so I saw real limitations. So I decided to leave the Air Force Academy, and I was kind of devastated by it, that my dream was going to happen. So I went to the University of Illinois, and I majored in biology, biochemistry. And so I'm still in the science end, but then I got into more life sciences. And so at the academy, we took a course in aerospace physiology, and I'm thinking, why do we need to know that? I'm going to fly fighter, but it's how the stresses of flights affect your body. So I started doing animal surgery there, and then animal surgery at the University of Illinois, and I had an aptitude for it. And so that's how I started getting into. I wanted to go to medical school. So I get into medical school, and then I really thrived. I loved it, and I got into more and more technology. I was surrounded by people who were excellent in their field. I went to Northwestern, and we had some of the top surgeons, and a lot of things were advancing in the field, and I was very, very excited. So then I decided I wanted to be an orthopedic surgeon, and so I went to the University of Texas Southwestern, where again, surrounded by excellent surgeons, the top of the field. And at the time, spine surgery was starting to grow. Texas Scottish Rite Hospital was one of the top pediatric centers in the country, and they were developing instrumentation for pediatric deformity, and that became Medtronic, the first pedicle screws hooking to put into rods that you could combine with hooks and wires and everything else for pediatric stuff. So we had that going on. And fortunately for me, my fellow wasn't interested in spine, and I was. And so we had guests coming in. Dr. Zilke from Germany came in for a month. And I had 4 years of college German, so I actually tried to talk to him in German. And I don't know if he appreciated it, but he was very, very kind to me and took me one-on-one with explaining how to derotate the spine from the front in smaller, tiny incisions. And I was hooked. And then Dr. Jean Dubisset came from Paris for 6 months, right after Dr. Zilke left. And Dr. Dubisset was derotating the spine from the back with pedicle hooks and such. And then the combination of things was going on at Scottish Rite. And so I was very excited about all that going on. So I left my pediatric rotation. I worked with Dr. David Selby from the Selby Award, started NASS. And Dr. Selby was doing all this surgery in lumbar spine for degenerative problems. So I go from the deformity problems to the degenerative problems. And Dr. Selby was just a master surgeon. He had great hands. In fact, his hobbies were woodworking. He would make totem poles out of wood, these massive things. And then he got into marble and he started doing marble sculpture. And it's incredible. He was selling these huge blocks of marble that he was creating. And he had the one I love the best. He made a skier hitting powder and the powder coming up. And so he wasn't totally self-taught. Some people showed him stuff, but he was doing all this stuff in his workshop. And then he would teach us how to do surgery. And he taught us technical stuff that made the surgery just go so well and so much easier. That the tissue would kind of just fall apart because he was in the right planes and he made us way better. So I have all this stuff going on in my life in spine. At the same time, early on in my residency, one of our staff guys was a fellow with Dr. Richard Steadman, the great sports medicine doctor. So we start doing all these cruciate ligament injuries of the knee because our ER was loaded with them every night. And so I had more cruciate reconstruction experience as a PG2 resident than probably anybody in the country. And so Dr. Steadman wanted me to come and go with him and do a fellowship. So I did a sports medicine fellowship with Dr. Steadman, and then I did a spine fellowship. And then Dr. Selby said, I want to change your fellowship. I want you to travel around the world with different people and learn whatever they're doing. So he sent me to San Francisco with the group there. And then he sent me to Iowa, the University of Iowa, to get more academic training and writing papers. And then he sent me to Minneapolis with Dr. Charles Ray and Dr. Chuck Burton, neurosurgeon. So I have neurosurgical training there. Plus Dr. Ray had, at the time I was with him, over 100 patents on cages and artificial discs that he was using. And then Dr. Steve Kuslich, was in Minneapolis as well, and he developed the BAK cage, the first interbody cage to be put in from the front, from the anterior exposure. So I got to know Steve really well and looking at his stuff and then was taught cage technology. And Dr. Selby had done a lot of anterior interbody work, but we were using grafts of, allograft bone, PEEK, other things, but now this is a threaded cage. And so then he sends me to London to work with Dr. Harry Kroc. So I'm in London, surgeons are called Mr., not doctors. So Mr. Kroc, for 3 months, taught me all this stuff he had developed in spine from the 50s on. And every Friday afternoon, we would go to the Royal College of Surgeons and we would do dissections. Because Mr. Kroc, during his training, in Oxford, was one of the he identified the blood supply to the femoral head with latex injections. And that created how we think about treating hip fractures. Then he also did the same thing for the spinal cord and the nerve roots. So he would quiz me on everything. He said, you cannot operate on a tissue you don't know the blood supply to. So everything was about fine technique, handling soft tissues delicately, repairing, anything. He actually slapped my hands one time with a retractor, with a forceps, because he didn't like the way I was holding the tissue. He said, Mr. Peloza, I've taught you better. You're better than that. You should never do that to a tissue. You're much too rough. Wow. So that's how I was trained to be precise, everything, just exacting, and treating tissue as if it were gold. It just has to, and then to understand what's going on, blood supply, nerve supply, how the whole picture works, not just go in there and pound something in. he would go crazy if you did that. And so I learned fine dissection. I learned the blood supply to everything because it was a daily quiz. And then he let me not only operate on his patients, but people would come to what they call his rooms, his clinic, Mr. Croc's rooms. And people from all over London, surgeons would come in and talk to him about cases, and patients would come in, and he goes, well, I can't go with you, but my fellow Mr. Peloza can go help you with that case. So I'm going all over London. And in those days, you didn't have to have credentials at every hospital. You just came in. You were the consultant. So I got a lot of experience doing that stuff, and I had a lot of confidence too. So I finish up my 2 fellowships and then the traveling fellowship in spine. I'm all over the world, and I'm seeing all different ways to do things. And so then I eclectically, I use what works for me. But it created this constant curiosity. And, never thinking you're the best, never thinking that things are settled. You can always get better, and constantly push improvement. And, when you think about some people think there's some eureka moment, like, aha, that's everything. It's usually more slow, steady gain. You learn something, you build on that. You learn lots of stuff from other people. You build on that. You collaborate. And so we had all these study groups when I was a younger surgeon, where we'd have like 20 guys from around the world in orthopedics and neurosurgery. We would meet quarterly, and we would discuss different issues, present cases, but then also design studies. So we designed a lot of studies from that group that actually got published. And it was a way to leverage our knowledge and then create a knowledge base in the literature. So that was invaluable to me. And so that got me in my career, that always thinking how to do it better.
Mm. So you said an interesting
running
thing.
to find my friends.
I'm sorry. You said an interesting thing. You referred to Dr. Selby, and actually that 6 or 7 years ago, that's where I first met you, was at the Selby Spine meeting in Park City.
Yeah.
JJ Abbott-Ball introduced us. But it's interesting because, and I have a question, I'm wondering if you think there's a correlation between good surgeons and their artistic ability.
Probably, for sure with Dave. What I've noticed with most of the surgeons I know, particularly on the orthopedic side, they're all athletes. And athletes have really good three-dimensional, they see in 3 dimensions. You see the whole field. Like Gretzky said, he never put the puck where it was. He was thinking about where it was going to be. So you have 3-dimensional. So to be a good surgeon, you have to think 3-dimensionally. If we look at an X-ray or an MRI, every frame is only in 2 dimensions. So you have to stack it up in your mind's eye to get the 3-dimensional view. And it's particularly useful in scoliosis or tumors, to see where the tumor is and get your clean margins. So most guys are athletic, and they have that mindset, but they also know how to work hard and to perform. That's part of being an athlete. Showtime, it's game time. You never shy away from that. Artistic, I never thought about it. I never painted or anything like that, but I can draw pretty well without any really training, because I understand perspective and light and how to make things look 3-dimensional. But Dave, he was incredible. I mean, he was on a whole nother level, and his hands, I mean, he was incredible in the operating room. And then, when I was first starting, I was a little slower. And he come in and goes, man, I'm coming here to put the spurs to you because you got to move it. This is just ridiculous. You're taking this much time to, well, I'm trying to do a good job. Right. There's some important stuff here.
Do a good job, but just do it faster.
Yeah. Anyway, and the thing about Dave, he was such a great guy, and he was so funny, engaging, and we used to, a lot of times at the end of the day, 4 or 5 o'clock, we'd sit down in a conference room and just talk about how the day went, or your cases or your clinic or whatever. And he was really funny. he also had so much courage, because in a day he was advocating for operating on low back pain with fusions, and that went back to the 60s. And I'm with him in the late 80s. He took a lot of heat for that, a lot of criticism, and he just knew he was right, and he kept proving it. And at the end of the day, there's the North American Spine Society, and everything he talked about that was controversial is now accepted. It's like, who would ever thought differently? Fortunately, before he died, he was recognized for his contributions, and he was, he's a great guy. I actually tear up sometimes. I think I miss him.
Yeah. Oh, I mean,
miss Mr. Kroc too. Mr. Kroc was the same way. Dr. Steadman died last year, and that was so sad, because here's another leader. So, you talk about, my career. I was fortunate to be around all these greats who were mentors to me. They taught me a lot more than just medicine. Actually, I always say, doctor, I thought I knew so much coming out of residency, it's hot stuff. And then I was with Dr. Steadman for a week, and I realized I didn't know anything. I need to shut up and listen to the master. And, he taught me how to treat patients. He taught me, he's such a humble guy, but brilliant. And he would figure out what was wrong and do just enough and not too much. So he got such great results. And, I was just picking his brain for a whole year. And then for the rest of my life after, I could always pick up the phone and call him. So I think if you're going to, it's important to be successful, to surround yourself with excellence and mentors who can really help you a lot. Because most great surgeons really want to help young guys and teach them. Yeah. And the other thing is, if you're a young guy, not to get so full of yourself that you can't take criticism, because sometimes the greats, they'll come down on you with both feet if you're not performing the way they think you should, because they have bigger expectations for you. So you can't get you can't get upset when you get criticized and even yelled at. And that's okay. I've been yelled at. Mm-hmm. So just go, okay, I got to do better. I can't, that's not good enough.
Yeah. It's interesting to see too, as surgeons sort of come to that point in their career many times when they recognize that they've been successful, but they really, in order to be significant, have significance, they really need to start investing into other younger surgeons. And you're proof of that. These people invested in you and had a profound impact, and still do to this day, even though they've, moved on, they've gone beyond.
Well, I think it was Sir Isaac Newton said that the reason he seems to be so brilliant is because he stood on the shoulders of giants. You look at our field, and we have historically in medicine, but pretty much in the last century, most of the advancements in medicine have happened. And in spine, I would say, you go back to the 40s, and scoliosis are putting in casts, and then Harrington developed the Harrington rods, which was huge at the time, but it created all kinds of problems because it was not biomechanically sound. And then people just got, thinking we got to get better and better and better. And now with the instrumentation we have now, it's unbelievable what we can do. We can control every individual segment of the spine in the 6 different ways of motion and stuff.
Yeah, it's remarkable.
We can do a lot of stuff.
I was around in the 80s selling for Zimmer, and we had Harrington rods and Lukey rectangles and wires, and by comparison, it's almost like Dark Ages kind of stuff. But
well, medieval for sure.
Right.
So I'm passing it. Yeah. Wow. The Lukey rod. I actually put in several of those when I was in training.
Yeah, I believe it.
Anyway.
Well, that's awesome. And I'm looking forward to hearing more on that. But I'd love to just kind of shift gears and let's talk to our other guest, Brad Niemann. And Brad, I just would love to hear you kind of give us a similar story about.
I'll tell you what, that is a tough act to follow.
I know.
But, I love that discussion. And, as I'm sitting here listening to Dr. Peloza, it really makes me think about all the great people I've been fortunate to be around in my career. And, it really goes back way before business. and of course starts with my parents who were married 61 years, and they're a whole nother podcast and a brilliant story that I'd love to share one day. But, my mom's 89, still out there playing golf once a week, and calls me and talks about how good her golf game was. She has shot her age. She's just a spectacular person. And, foundationally for me, great family that really was centered around athletics. And, I'm the youngest of six. Everybody played sports at a high level, high intensity. My second oldest brother played for the Chicago White Sox in their system for a while. I ended up playing college basketball at DePaul University. And, one of the great legends of college basketball is Ray Meyer. And I got to play for his son, Joey Meyer. And so, I was just so fortunate to have great coaches in my life. And, it's the same parallel, Dr. Peloza, to all the great surgeons that you got to train under. I got led by great coaches. And, so much of that translates to the business world. I mean, leading an organization and leading teams, I don't think there's much difference to it. So, I never in my right mind thought I would be leading a spine implant company or having the medtech career that I've had, because I came from that athletic background and I wanted to be in sports, whether it was going to be a coach or an administrator. I thought about being an athletic director or something on the business side of sports. I wasn't good enough when I was done in college to keep moving forward as an athlete. But it was such a big part of my life. I just felt like that's really my fabric and, kind of how I'm wired. And I ended up back at DePaul University as part of their athletic department on the business side. And one of the individuals there went over to the Orthopedic Research and Education Foundation as the director of development. So OREF is, I'm sure you're aware, is part of the academy. It's out in Rosemont, right next to the airport. That's where the office is. And John asked me one day to come over and be one of his development officers. So for my entree into orthopedics was raising money from orthopedic surgeons and the orthopedic community. And I was only 24 at the time, and I knew nothing. And the only time I'd ever been in a hospital was, injuries related to sports. And at OREF, I look back on it now, and, years ago I looked back on it. The OREF board at that time were, you talk about the who's who foundationally of orthopedics: John Brown, Dane Miller, Richard Rothman, surgeons. It was made up of the board at OREF to raise money for those research projects that weren't funded by the government or other institutions. OREF raised a lot of money. In fact, I think at one time it was the largest private fundraising of any medical organization out there, or arm. So it was a lot of annual money, and and I got to learn and see and interact with the leaders inside of orthopedics and spine in all aspects. And I was very young, and I had no idea what I was doing or who I was talking to. But part of my job was to raise money for corporations. And there was a company in the early 90s that was formed called Orthologic. And my first job in 1996 out in California and was with Orthologic. And that was because I met the leadership team, which was Dr. Fran McGee, Alan Weinstein, and a gentleman named Dave Derminio. And Dave became a great friend and mentor of mine and said, "You would be great to lead our team on the West Coast. Do you want to come work for Orthologic in 1996? I said, "Sure." And that was my first corporate job as the Western sales manager. I had never led a sales team. And I was 26 years old, and I showed up in San Francisco area, in the Bay Area, in Walnut Creek, and had a high performing, very successful team of direct employees that all of a sudden this 26-year-old was their boss. And they were all older than me, and they were all very successful. But the one thing I realized, and it's, to echo some of your thoughts, Dr. Peloza, is I knew what I didn't know. But I did know how to work. That work ethic derived from sports. I knew how to compete. I knew what the objective was, and that was to get better. So I made no bones about it. I knew what I didn't know. And all I told that team was, I'll do everything I can to support you, and I promise you, I'll most likely work harder than you. And over time, that's how I would like to think I earned my respect, and very close to many of them. What's interesting for me, and that's many, many years ago, I was just in the process of hiring one of those people that was originally one of my sales reps in my first job. And almost all of them are still in the industry. And it was, I was very fortunate to make a decision on a whim, jump into a company that I knew nothing about being, other than raising money from surgeons. I knew nothing about the OR. I knew nothing about the technology. But, I jumped in, and I would like to think I just, used my experience in sports at a high level. And I just leaned on what it took to be successful in athletics and just applied that to the business world. Because that was all that I knew at that time, and to treat people well and do the right things. And then we got bought by DonJoy, which is now Innovis. But at that time it was DonJoy, and then it turned into DJ Orthopedics and DJO Global. And again, I think that is really where my career, I would say, took off. Before we started this, Drue, we were talking about Les Cross, Vicky Capps, and Luke Fallstick. And, DonJoy is an incredibly successful story. I would argue one of the most successful stories in our orthopedic industry. A brand name that very few people don't recognize. And it shows up on Sundays and Saturdays in sports and the football field every day. And these were three of the best executives that you could be fortunate enough to work under. And again, very close to all of them and have the utmost respect for them. And that company, I think when we started, we were about 130 million. And when I left to Orthofix in 2012, it touched $1 billion in sales. And what a ride. Great people, great process, really understood how to be in an environment of continuous improvement, just always searching to get a little bit better, and I mean, that has stuck with me. And it's probably the number one thing I talk about at 4Web today is, 3 months from now, let's be a little bit better than we are today, and so on and so forth. And if you stay committed to the process behind of improvement, there is no trick to this. It's just that fortitude behind it. And I had a great opportunity to be part of Orthofix from 2012 to 2020. And we did some great things. Very proud of that time, very proud of the time at Orthologic, very proud of the time at DonJoy. And Orthofix was a different story. It was more of a turnaround instead of a growth. But through that turnaround, we ended up growing pretty significantly. And, it was another chapter of great people. And I would say that was a little bit different. Great executive team, great partners, but an incredible sales organization. That's where I would say a lot, if not all, but a lot of my relationships on the commercial side really rooted at Orthofix. And, I was the president of Global Spine there. And today over at 4Web, I'm tapping a lot of those people on the shoulder and to say, I need you to partner with us over here as well. I think to talk about 4Web here and my transition there, it started at Orthofix in 2019, maybe it was 2018. had an opportunity to interact with Dr. Frank Camisa at HSS. Wonderful gentleman, really got to know him. And he just made a comment. And I was taken aback by how enthusiastic he was. And he pulled out his phone and he said, the interbody Orthofix should buy is 4Web. And he pulls out his phone and starts showing all these x-rays. And he said, look at how good that fusion is. Look at how good that fusion is. I mean, I sat there for 10 minutes with Dr. Camisa, and he grabbed our CEO, Brad Mason, at the time and said, see, look, you need to guys go buy this. So I think on Monday, that was like on a Saturday, he was in for the Giants and Cowboys game because he's the team doctor for the Giants, one of the team doctors. And I think on Monday, we went to the board and said, give us approval to go kick the tires at 4Web and see if that's an acquisition that we can get across the line, which is literally a mile from Orthofix. So Orthofix is in North Texas, and 4Web's a mile from it. And so I got to know 4Web in 2019 and really admired the technology, really admired the people, really admired the organization. It had a different feel to it. It wasn't like every other, in my opinion, spine company that was just trying to create a portfolio and sell it. It was so dedicated to the why the company was formed, and that's the truss technology. And it has always thought of itself as a technology company first, not a commercial company. And I really respected that. And being from Frisco, got to know the owner, Jesse Hunt, pretty well over the years. And then circle back to last summer, 4Web did what I think is an incredible job of keeping its head above water during very difficult times of the pandemic. And as you can imagine, and Drew, you would know this better than me, is those smaller companies that don't have that bandwidth and that depth to survive, these times when those cases took such a dramatic downturn, and to keep the cash flow going and keep the lights on. And I give Jesse as the CEO and the entire team there so much credit for persevering through such a challenging time. And then recently was able to sell off the rights to the foot and ankle applications to Stryker's foot and ankle division. And the milestones and the money associated with that transaction has really propped the company up to reduce debt and to really prop it up for its next cycle of growth. And, I get a call from Jesse, and he and I see each other, and we go have lunch, and he says, we're ready to hit the gas here and take the company out of neutral and start going forward. And I said, man, I'd love any opportunity to jump on board with that and help you do that. And so I joined the company 6 months ago. Great decision. Couldn't be happier. It's better than what I would have thought. And I think our opportunity is in front of us, and it's within our control. It's within the decisions we make, the people we hire. And I'm just excited. But the journey here, I guess in my 30 years, starting with really a risk decision to move out west and live in San Francisco where I knew nobody, to lead a sales team at a young age, I just jumped into it. And I've been very fortunate to have a lot of great people along the way that I've been able to learn from, and mostly give me an opportunity and give me the trust. So I take my responsibility of leading an organization very, very seriously, because I know that it's not about me. It's about the employees. It's about the shareholders. It's about the people. Like I'm a steward of the company and all the aspects of it. So it's really not about me. I look at it as what I'm responsible for and whom.
Yeah, that's great. No, I appreciate that. And I would love to pull Dr. Peloza back in on this because, you mentioned your involvement in a lot of these, with some of the guys like Kuslich, BAK, Cage. I mean, you have been around and have seen this evolution and the twists and turns when it comes to the interbody cage. And I would love to hear how you have seen the evolution occur, and what was in your decision criteria as you've kind of looked at even where 4Web is and why maybe you've sort of moved towards that direction.
Well, the interbody space is the place to put a graft. Greater surface area under compression, and you can control the curves of the spine, particularly lordosis. In addition, by putting it there, you don't damage the posterior musculature. Those are the dynamic stabilizers of the spine. One of the reasons cervical spine surgery is more successful typically than lumbar is everything, most of the time, is from the front. So you don't damage the normal tissues. So then it became how to get to the front of the spine better. And then put in a better graft. I mean, initially, we're literally, Mr. Kroc used iliac crest dowels, and they healed great. And you're thinking, oh my God, talk about primitive. But he was such a master craftsman, as was Dave Selby, that they could get anything to heal. So then when at about the same time, there was allograft rings, which is a pretty poor model because allograft's a piece of dead bone. So your cells have to create channels with the osteoclasts into it, and then the osteoblasts to make bone follow. And that takes a long time. So Bagby developed a cage for thoroughbred horses who would get they would get quadriplegia. And those are valuable animals. And so he would take the disc out and he put a cage in to stabilize it with bone graft, and it worked. So that's actually the origin of the Bagby cage. And so Steve and Dr. Bagby then developed it for people, and they made it a threaded cage. So it threaded into the bone. So very stable, and it had lots of advantages. It had some disadvantage too, because it damaged the end plate to some degree. And if there was osteoporosis, it could be an issue. And if people did it poorly or in the wrong indication, there could be a problem. So again, innovation. Dr. Steffi had a carbon fiber cage, and then there was the original Bagby customers is titanium. The titanium loves bone, so it heals nicely. Stainless steel doesn't do that. So there was different materials and everything. So we get to all these different cage designs. So what's driving it is doing better, but also getting around patents and stuff. So that's not necessarily a bad thing, because all of a sudden better tech comes around. So you had basically open cages filled with bone, and then the LT cage came along that put in lordosis. Again, a threaded cage, but then it was put in with bone morphogenic protein. So I was involved in that study too, using a biologic to create bone. And BMP is what infuses, had been discovered by Marshall Urist in the mid-'60s, but nobody knew what it was. And so that was refined. And then the Medtronic guys figured out a way to industrialize it and make it pure. And it is a very powerful molecule. So it really created very consistent fusions. But it had a downside if it was used wrong. If it was used in the posterior canal or something, it could grow bone where you didn't want it to. It could create all this inflammation. We didn't really understand it in the lumbar spine because we never really had to go back in the lumbar spine and revise much with the LT cage with infuse. But in the neck with dysphagia, we've discovered that the inflammation caused by the BMP could be a real big problem. So anyway, the indications were refined better. So then other cages come along, and they all have pros and cons. They different ways to make to expand the spine, create lordosis, create a consistent bony fusion. So then there was this surface treatment idea, laser etching, that would create an osteoblastic response. So we worked with one of the companies that did that, and although the concept was good, I was pretty unimpressed with it in terms of how it worked physiologically. So I'd worked with Jesse and several of his distributors on different things, and so they showed me this concept. And going back to my engineering background, what is a truss? A truss is a fundamental biomechanical design. And if you look at bridges, roofs, like in a gymnasium or an open roof, those are all trusses. And the reason they're there is because of the loading is so beneficial. It's also lighter. So you have a lighter structure that's stronger. The other thing that happens with these things is if you load one part of the structure, you uniformly load the whole structure. So you don't concentrate stress in one spot. And one of the problems, if you do that in a biological construct, it can fail. If you're relying on one pedicle screw and it's under shear, it will fail. And then you got a bigger problem. Now you got broken hardware in a non-union. So you're putting this structure in the interbody space under compression, which is you're putting all the factors for success. So when you look at a truss, think of a triangle. When you load a triangle from the top, the sides are put into compression and the bottom in tension. And if you reverse the load, the tension compression components change. So it's a dynamic load. And as you load it, it's changing the length of the strut. Right. So what has been shown is that when you line the cells up on the strut, and the strut is designed at a specific dimension to get this effect, okay, the length change in the strut is at the nano level, like 39 nanometers. So that level of change in length is a mechanical signal to the cells lined up on the metal to make bone. It stimulates osteoblasts. It stimulates the production of growth factors, which is BMP is a tissue growth factor.
So the structure of it does that, not only the material itself, but the way that the structure is loaded creates the mechanism for bone on growth and true growth.
Right. So the material is titanium. So bone already likes that. And so the bone cells line up on that, but it's the mechanical stimulation to the cell to create bone. So you can put in any kind of graft and it's pretty significant, it usually heals. And then you can put a biologic in too, and it heals even more effectively. So this was a really different mechanical design, a different engineering design than all the other cages preceding it. And so there's several other factors that are really good. For instance, the cage takes up the whole disc space, and you can put it on the strongest part of the disc space, the peripheral end plate. And it has this truss effect. So it's like a snowshoe in snow. It distributes the forces in a wide area rather than in one spot. So instead of punching through the end plate or punching through the snow, you get this uniform distribution of forces. And then you get the mechanical loading that is the signal to the cells to make bone. And then, so everything's in favor. It's just really unique engineering. So then you got to make it. So then they figured out how to make it with 3D printing and processing. So that's an addition. There's different mechanical processing. You can do subtraction or addition and how you do it. But there's nothing special about 3D manufacturing. Everybody can do that. It's the truss that is different. And so a lot of my colleagues think what I just told you is just nonsense. It's rubbish.
Really?
And they don't like the 4-web because they can't see the fusion as well, because the whole internal architecture of the implant is trussed. It's not just one truss, one triangle. The entire architecture is triangles, all being loaded. And so we've got a lot of biomechanical data on how what I said is true. You load it in one spot, it's uniformly distributed. Lisa Farrar's lab's shown that forever, where all the forces are. And then, Tim Gainey, they saw the the BMP production, also the the markers on these cells showing increased activity. So it's real science. It's not nonsense. But a lot of times when we evaluate a fusion, we do a CT scan with thin cut sections in coronal sagittal planes and through the cage to see the healing. Well, in a big open cage, you can see that a lot easier. But in a truss, you have to go frame by frame to see the bone growing through it, because it's not all, one cut doesn't get a uniform picture because you're going through all the different trusses. So you have to take your time to go through it and see it. And so they think, not true. But it is true.
Well, Brad was saying earlier that the doctor he saw in New York spent 10 minutes showing him x-rays. So do you have to relearn how you view the films?
Not so much. You just have to understand the implant. And I was thinking when you were saying that, Brad, I was saying, we don't have pictures of families in our phone. We have pictures of patients and implants. It's so weird.
It's funny. You go to a society meeting and you see surgeons on their phone going like this. I know what they're looking at.
Yeah. How's your son doing? Yeah, he's fine. But look at this case.
Exactly.
I think there was lots of us who saw the advantage of it and use it in our practice, and some still just don't like it for whatever reason, but that's okay. In fact, most cages work pretty well, but fusions are you're in almost it's rare to have a non-union anymore because the technology's gotten that good. But anyway, by having a large implant that you can control the curves of the spine like lordosis, because one of the problems with fusions in the old days was creating flatbacks. A flatback deformity is a disaster. It transfers forces to the next level at a much greater rate than a normal fusion would. And so that adjacent level disease is a real problem. It's still a problem even in perfect fusion, but it's really bad if you create a flatback. And now the total hip guys are relating flatback or deformity, a fusion, stiff spine to its effect on the pelvis and how the pelvis moves to how they position their components in a total hip replacement. So it's really important to get your correction in the lumbar spine correct, get it right. It's not physiologic. A fusion's not physiologic, but at least in a better position because it affects everything else down the road. So one of the biggest things that can go wrong with a hip replacement is a posterior dislocation. So when they see a stiff spine, or particularly, we have all these parameters. We use pelvic parameters and things, lumbar lordosis that we measure. Well, they measure that and relate it to the hip as well. And so that all has to now be taken account to get a good hip and lumbar spine result. So anyway, it's and the thing is, if you put a really predictable implant into the interbody space, you can now do it through minimal invasive techniques, an MIS A-lift or an O-lift or an X-lift. Just tiny incisions where you don't hurt the normal tissue, and you just put this in, and it's very powerful. In the old days with scoliosis, we had to do all these osteotomies. And one of the challenging operations with a high complication rate is a pedicle subtraction osteotomy, where you have to create all this lordosis. Well, if you go in for the front and you create the lordosis through a cage device with minimally invasive technique, you can correct a curve without the big osteotomy and then just put screws in percutaneously with navigation or a robot. That's a huge improvement in the old days. So you're talking about hardly any blood loss. The risk to the nerves is minimal, and no soft tissue damage to normal tissues. And it's because we have these very powerful implants that we can put in the disc space.
One of the things that you said struck a chord with me relative to the design of the cage, and that is, you said, if I'm not mistaken, that you put in a bigger implant that's broader because of the architecture and allowing you to put bone in it the way you do. You're not putting a small cage in and surrounding it with bone. It sounds like you're actually putting them, which gives you a greater footprint, which then should lead to a less incidence of subsidence. And then you add to it that snowshoe design that kind of just intuitively makes sense that would reduce the incidence of subsidence.
Absolutely. It's really unusual to get subsidence in a four-web cage. Possible because, as you expand the indications, you get to the osteoporotic problem, and that's when it becomes more of an issue. But even if it subsides, it's generally not terrible. It may subside a little bit, but then it stops. Particularly, you have to put posterior instrumentation in too. But it is the best cage for that. So one of the big problems with, say, a T-lift cage is it only goes into a small part of the end plate, not the whole end plate. And the reason for that is because we can't get these massive implants in from the back because of the tires are in the way. So anterior lumbar interbody fusions, oblique fusions, and lateral fusions can put these larger implants in that are much better fixated on the strongest part of the bone. Subsidence is much less. So you can correct a scoliotic deformity really effectively this way. It's very powerful. So you correct for deformity. You don't get subsidence. You get a really predictable fusion. So all of those factors are really key to get a good outcome. There's a lot of literature saying that the T-lift results are so good. So I've been at a podium before and say, well, if it's so good, I must be seeing all the failures because I'm making a great living revising T-lifts. So, and then what I get is a chuckle from the audience and go, yeah, me too.
So obviously, we've seen this progression from bone dowels to PEEK to titanium to etched titanium, and that's obviously taking a new look at kind of the architecture and creating some benefits from that. But what about clinical evidence? I mean, it seems like a lot of companies come out with new flashy products, but what kind of clinical evidence do you guys see from the performance of this on a more long-term basis?
The difficult thing about proving this in a level 1 study is that you have to get, the reason the study groups worked is because we had like 20 guys with 20 different practices to create a lot of volume. You need to have a lot of cases to show a difference to be statistically significant. Plus the expense of it now. I've been told that FDA trials now are $80 to $100 million to do, take about 4 to 6 years before, you get approval by the FDA. And the insurance company still, you get about 5% approval rate. So that's your commercialization. So at the end of the day, nobody can afford it. And so that's I think the biggest obstacle.
Drue, one thing that 4Web engaged in over the last few years was partnering with UPenn and their research team. And we've just completed our manuscript and have just submitted for publication what we think is some exciting data that will support the concept and the impact that the truss design has at a cellular level. And so one way for us, instead of doing a patient-based study, is really to look at that gene response and the osteogenic effect of truss from a basic science standpoint. So, the intuitive engineering part of it combined with that research that the company's engaged in, I think tells the story pretty well.
That's great.
Yeah. So that's all good. And so then they said, well, it works in theory. Does it work in practice? So then you have guys, pull cases together, but it's not level 1.
Right.
It'd be like a large prospective cohort, which would be level 2, or, retrospective data collected prospectively, but that's a level 3, 4. And so a lot of people don't care about that. Or it'll be a white paper from the company and nobody cares about that. So that's the trouble. So you need study groups that help with that, or you go to a university that's committed to it as well. But I don't know what your numbers, like 100,000 implants, something like that now.
Yeah, just announced that a few weeks ago. The company surpassed 100,000 implants, and
yeah, so
that's a huge milestone. And I will tell you, I looked at 4Web in the past and joined them recently, and it really stems from the conversations with surgeons. And I have rarely, probably never, have heard a surgeon say anything other than "love the 4Web cage." It's the feedback.
Well, there's some guys who don't.
Well, I don't like talking to them, so never mind.
That's okay, though. That's what, Bert Mooney was my old chief, and he used to say, well, when somebody had a different opinion, they said, well, he would go, well, that's what makes horse races. So, you do what you want, but anyway, it does work. It works pretty effectively. And, that's my go-to implant. There are others that have open architecture and different designs that are very effective as well. So now they're really getting sophisticated with surface treatments, and they're recreating almost the architecture of trabecular bone. So it's just getting better. What was a point I was going to make? I've been thinking, and I don't know anything. I'm not an expert in artificial intelligence, but I've been thinking that artificial intelligence is being applied to a lot of things. I've used it more for searches because it's really quick to get a search done and it can help you write papers faster and stuff. And then I've been thinking of how to apply it to my practice to make us more efficient as a practice, because as a physician, you have all this paperwork for insurance companies, and it's crazy bad. So can artificial intelligence make that more efficient? The other thing is, can it make studies more efficient? Can we predict outcomes with artificial intelligence putting in this information? And so you don't have to do a study of, say, hundreds of patients with a minimum 2-year follow-up. Will take you usually 3 to 4 years to get everybody enrolled and follow up for that long. Can artificial intelligence make that quicker? Can it predict it? And I bet it can. I just don't know how to do it. So this would be a job for the guys who are into that, say Elon Musk and his people, or I forgot the other guy's name, Chat GPT guy. But there was some article, a fellow of Ambitious, I think his name is, and he's talking about artificial intelligence in 5 or 10 years being able to do pretty much everything we as humans do, and have the ability to think independently, not just to grind numbers, but to predict disease or treatments for diseases.
Yeah, I think it's interesting.
I bet that's possible here too.
Yeah,
and man, that'll make things so much cheaper and quicker.
Yeah, I think it makes a lot of sense that we already can do that with computer modeling to some degree, testing constructs, different constructs. What's the strongest? What's going to perform best under load and cycles? And so I think you're onto something there, that if you took the capabilities of AI and just looked at all the different studies and looked for correlation and crossover for failures and what you might attribute them to, or survivorship. I think that's a really interesting thought. I'd like to see somebody take that on.
Yeah. I think I could understand it if somebody did that. I would not be able to do it myself. I don't have any training for that. But fortunately, there's plenty of guys who do, and I bet they could be hired to do that project. So that's fun. That's kind of the future, when I look at where we started from where we're going now, the amount of improvement and stuff has been really remarkable, and I think it's going to accelerate. So we're going to be able to do stuff with, right now we're into a lot of motion, as well as we can do hybrids and disc replacements, and we'd like to keep people moving as long as possible. Regeneration, the studies just coming out with allograft disc cells is very impressive. So I think that's going to be something in the future too. We used to take big bone grafts and stuff. I haven't taken a bone graft in probably 10 years.
Well, it's always been the case where it seems like the surgical site was not painful, but the harvest site was always the big problem for people, and the patients complained about that.
Yeah, the cuneal nerves that go over the iliac crest, so you have to know where they are so you don't damage them. But even as something as simple as navigation, we put a little post in the pelvis, right at the posterior superior iliac spine for the navigation reference. And that can sometimes hurt more than everything. I'm like, how? So anyway, we've done different injections of stuff in there that's helped that. So, part of your question when you were talking before the meeting was, innovation, what drives innovation and stuff, and what's going to stop it, what's going to be a problem. And the problem would be cost. So the cost of doing these studies, so if that can be lessened and more predictable, that would be helpful. And then all this great stuff, somebody's got to pay for it to put it in people. So that's the commercialization. And a lot of folks think that's a dirty word, commercialization. But if you can't commercialize something, it won't happen. There's a reason nothing happens in sub-Saharan Africa, for instance. There's no point. You think about the rise of Western civilization. It was because in Western civilization, education was valued. Universities were created to create knowledge base, manufacturing, products, trade, and it went crazy. It really expanded, dominated the world. Now Asia has discovered that in the last 100 years. So, you go back to the Industrial Revolution, it was taking ideas and making them practical in real world. Knowledge for its just esoteric value is kind of fun at a dinner party, but if you can't commercialize it, it's just fun.
Yeah. You need people who can do the strategy, and you need to have people who can create really innovative products, but without the commercial execution, you've just wasted a lot of money.
Yeah. You look at Elon Musk, his genius is because he can do the thing from A to Z. He's the innovator, designer, and a brilliant businessman, and commercializes all the stuff. It's amazing to me that when I saw him, SpaceX, bring that booster down, because like I said, I was into the space program, and all those things went off. The booster just got jettisoned in the ocean, never used again. Then he brought that thing down in between the chopsticks in his tower. See, when I was a kid, we used to have model airplanes, and I used to do the Estes rockets and all that. So you have to have flight surfaces to control it. And I'm looking at there's no flight surface. He's doing it by differential thrust on his engines to get it to. How does that happen?
Yeah.
So, you look at a guy like Elon Musk, and without a capitalist system, he's just a weird guy with great ideas.
Yeah.
But holy cow, the stuff he's coming up with. And so when you talk about innovation, you have to have the whole piece. That's why surgeons contribute. Some business guys do what was fun about in the old days, we would do a lab, for instance, and we'd be on the cadavers, and we'd be designing the operation from A to Z. And what part do we need? What do we need? What part do we need to do what? And so there'd be engineers, a project manager or two, and a couple surgeons, and we'd be doing this, and we'd be drawing stuff out, and the guys would be making designs, and like in a couple of weeks we'd have a prototype, and we'd repeat the lab again, and we'd have another prototype. We'd make it better and better and better, and then there would be a product, and then we would actually use it on cadavers again and again until we had something that was really good, and then we would do a study. So but it's a collaboration. Nobody knows everything except maybe Elon Musk. But so surgeons know what they need in the operating room. We've got a problem we need to solve.
Yeah.
Engineers know how to make stuff, how to design stuff. The engineering, the project managers know how to get things going, keep making progress. The manufacturing guys know how to make it now that basically computers can make all this stuff. And then the business guys know how to put together capital to make a company to make it all work. And if all that's not working right, there's failure.
Yeah.
So
that's a great point.
So these people who think that business is bad and profits are bad, it's just foolish.
Yeah.
They'd be living in the medieval times if they think that's so.
So Brad, that's an interesting segue to talk a little bit about the company. And obviously, you can't innovate without working with people like Dr. Peloza. You need forward-thinking, innovative.
Absolutely.
So, I'd love to just kind of hear what is in store for 4Web. Where is the puck going, to use the illustration that you used before?
Yeah, well, I mentioned the opportunity in front of us is really getting, I would say, the company back into an acceleration mode. And in our world, that starts with, I call it, three things: product, people, and programs. And we're in the product business. We want to stay close to our core competency and truss design. There are segments of the industry or segments of the implant portfolio that we're not in. One example of that is expandables. And there's other parts of our portfolio that could be rounded out. So I think first and foremost, low-hanging fruit for the organization is to go do those things that we can quickly do, get out to the market, leverage the customer base that's been built for many years. We got a great sales channel. We got a great amount of support from the surgeon community. And I think there are some easy wins for the company. And we're in a capital position to do that. And we've got a great engineering team, great sales team, and just everybody that's really committed to creating the next chapter for 4Web. So I would say the first thing for us is to just create some immediate growth through product launches. But I think long-term is how do we continue to prove out the impact of the truss design clinically? I also think about, we're talking about AI. We're talking a lot now inside of orthopedics about the materials that we use. We're a titanium-based product, but is there opportunity for us to look at coating that? Is there other materials out there that also lend itself to a truss design? We're starting to see more and more hints. Is there an opportunity for us to think about partnerships on the biologic side that combined with the truss impact really accelerate that fusion? And so I think there's a lot of innovation in front of 4Web. But in the near future here, we want to get back to executing and launching new products, I would say over the next 18 months. And we've got a whole pipeline. So I'm having fun building out the organization and with the people to support the products. And then I call it programs. And that's everything on how we interact with the surgeon community, the number of labs we do, how we market, how we tell our story, and all those programs. So I love being in a growth mode. I love seeing if we can wake up one day 2 years from now and the company's on its pathway to be double the size. And it's just, and that's a lot of fun. And, the amount of impact you can have on employees and others that are involved with the company by doing that. For me in my career at this point in time, that's as gratifying as anything, is see the impact you can have on others.
Mm. Yeah, that's great. Well, in terms of kind of where we go from here, I guess I would just thank you both for spending some time with me today. And I really appreciate just the time and all that you shared. And so, Brad, if someone would like to learn more about 4Web, what's the best way that they can do that?
Well, I think from what Dr. Peloza said is I think we're going to publish his phone number, and I'm going to first ask him to call Dr. Peloza. No, but our website, 4webmedical.com, is probably the easiest way to learn more. We're just excited. I mean, we're very active in social media. Drue, really thank you for creating this platform inside of orthopedics. I think you're going to have huge success in doing this. Our social media, whether it's LinkedIn or Instagram, I think 4Web's out there pretty regularly now.
Awesome. Well, any parting words, Dr. Peloza?
No, I think, I always got parting words. I think the future is great. I think the healthcare system's got some real struggles, financial and different control issues. That'll be the thing that'll screw it up. But the science part's great. It's been no better time to be a doctor. The difficult thing is there are factors that are beyond this website right now, or webinar, that or podcast that we could do another podcast on, that are really a challenge to providing good care. So we're and in my practice, we're getting out of the insurance world. We're doing more concierge stuff, and so our website is pelozaspine.com. You can learn about what we're doing. But we're thinking ahead of all the most advanced technology, the way to apply it, and it's a combination of things: fusions, disc replacements, motion, minimally invasive endoscopic surgery, and biologics and regenerative techniques that we're in the forefront of. So that's where we're going. I think we're going to make some more progress, but the challenge is the medical, legal, government stuff that's a real problem.
Yeah. I don't know if you've been following it all on some of the social media, a gentleman by the name of Dutch Rojas, but he's been pretty vocal about some of what's broken and trying to, effectuate some rational, thinking in Washington, D.C. And so,
Well, I do follow Mr. Rojas. I haven't met him, so I, calling him Dutch seems to be presumptuous, but he's absolutely correct.
Yeah.
And private practice, private medicine in this country has been wrecked.
Yeah, I'm going to have him on another podcast here in the near future. So stay tuned.
Yeah, so now we've got these large monopolies, and it's really going to be hard to get around that. So this is our plan, our business model, and so far it's going pretty well. But I don't know. I think it's going to be successful, but it's a shame that we have to do this. But
I agree.
Talking to my European colleagues, the same things happen in there, and so maybe another podcast with. I'd like to meet him. I think he's really spot on on that. So anyway, pelozaspine.com is where you'll see what we're doing, and I guess that's my last thing.
Awesome.
I'm really happy I'm a doctor, but it would have been great to be a fighter pilot. I still pine for that.
Do you have a simulator at home at least you get to play with?
No. I was going to take flying lessons and all that, but, I was so busy in my career early on. I mean, literally 80 to 100 hours a week, that I would never fly enough. And so I figured I'd auger myself into a mountain or something somewhere. And I just didn't think it was safe.
Well, and we just had two of those recently in the last couple of years, two spine surgeons who both, their lives ended abruptly because they were flying. And so,
Well, Pierce Nunley is a pilot, and he's, I've been in meetings with him. He's making his flight plans, and he flies a lot. So he's doing it right. But I figured I just thought it would be a mistake. And so I decided never to do it. But
well, I I agree with that. You may have some regret in the near term, but I think it's a good choice.
Yeah.
All right, gentlemen. Well, thanks again. Appreciate both of you and your time and just your thoughtfulness through this discussion, and best of success to both of you as you move forward.
Okay. Well, thank you so much.
Drue, thanks so much, Dr. Peloza. It's great seeing you.
You too, Brad. Take care.
Okay.
Bye-bye.
Bye now.
Bye-bye.